she's okay there. So, first of all, I want to welcome you all coming here tonight. I'm Dorothy Poppy, and I'm the CEO of Bobby Jones Chiari and Syringomyelia Foundation. I don't know if you've been to the website or not, but if you do go to our website, there are 764 videos similar to what we're recording tonight, which is a good resource for patients once they get home. Tonight, of course, we're doing this amazing video. And honestly, I don't think we've had anybody like Dr. Pareto do anything like this, so I'm really excited. Dr. Henderson is like our expert, truly an expert for all these years for us. So we're very grateful that he came down to do one of these here. He's involved in a number of research projects that we're working on. So I encourage you, I don't want to take too much time, encourage you to go to the site, learn about the research and the education projects that we're working on. If you have any questions, please reach out. We're in the office 7 days a week. Thanks. And now, Dr. Henderson.
Dorothy has put together the most amazing medical foundation in which there are about 80 neurosurgeons from around the world. And I don't think there's any other foundation like what she's done. And the lectures, I know about 4 years ago, they'd been looked at 1.5 million times. I don't know how many millions now. So thank you, Marcia, for inviting me today. And I'm going to talk about cranio-cervical instability in the broad and narrow context. So I'd like to, there you go. I'd like to honor some of my mentors, Dr. John Jane, Fano Perot, and also Professor Alan Crockard, with whom I studied, did my fellowship in London at the National Hospital for Neurology and Neurosurgery. And it was during that time that we saw a lot of connective tissue disorders, including rheumatoid arthritis, not much EDS, a lot of osteogenesis imperfecta. And that got me thinking about the whole problem of brainstem and spinal cord injury, something that neurosurgeons didn't really know much about at that time. And we thought that people suffered brainstem injury as a result of ischemia, decreased blood flow due to the pressure on the brainstem. And what we showed in our study, neuropathological study, was that it's actually not so much blood flow as the mechanical deformation and stretch and distortion. And we published that, and then later published with the chairman at Cleveland Clinic, stretch-associated injury in the upper spinal cord and lower brainstem, which I think is very pertinent to the Ehlers-Danlos syndromes, where the ligaments allow too much stretch and deformity. And then in 2018, we looked specifically at the neurological and spinal manifestations of Ehlers-Danlos syndrome, of which Chiari malformation happens to be one of the more common. And it's important because Chiari malformation, which is this descent of the cerebellum shown by the red arrow through the base of the skull, the foramen magnum, that causes obstruction of spinal fluid flow and also puts pressure on the back of the brainstem. And it's treated with a suboccipital decompression shown on the right, removal of some of the bone. But this commonly occurs with Ehlers-Danlos syndrome. Chiari occurs in 1% of the population, but perhaps only 1 in 1,000 might need surgical treatment. And 13% of Chiaris are occurring with Ehlers-Danlos syndrome. But more recently, Dr. Santu at Georgetown University noted that 80% of the failures of Chiari decompression had Ehlers-Danlos syndrome. And so he felt that symptomatic cranio-cervical instability should be recognized as a delayed postoperative complication of Ehlers-Danlos syndrome and other connective tissue disorders. So others have hypothesize why decompression for Chiari fails, and it's a lot of the reasons
Something went wrong there, Dr. Henderson, for some reason.
relate to pressure on the brainstem and deformity of the brainstem and stretching of the brainstem. These are all issues of mechanical deformation, and particularly pertinent to
We'll come back in a second.
Ehlers-Danlos syndrome. So brainstem deformity, the Fulcrum effect due to the top of the spine pushing on the front of the brainstem, and atlantoaxial instability, and of course craniocervical instability, which is the main issue we want to discuss this evening. It didn't come out for some reason. In Bruckmeyer's papers, approximately, they looked at 100 patients with Chiari, and 20% of these patients needed a fusion, and that fusion was necessitated in most cases by kyphosis or angulation of the brainstem at the base of the skull and basilar invagination. So we want to talk about instability at the craniocervical junction, and it's important to recognize that any patient with Ehlers-Danlos syndrome has hypermobility in every joint in the body. And hypermobility is not necessarily a bad thing. In fact, it probably makes swimmers faster and sprinters faster. But when it reaches pathological levels, of course, it's very harmful. So hypermobility itself is not necessarily instability. Moreover, if you have radiological findings of that might look like instability, it's not necessarily accompanied by neurological changes. So when we say craniocervical instability, it should imply the presence of neurological deficits and pain. If there's no pain, no neurologic deficits, then the radiological findings are not as important. It has to be the whole clinical picture. So just a little basic anatomy here. There's a view through the middle of the brain, and that big bony structure at the base of the skull, that's called the clivus. And at the very base of the clivus is that edge of the bone is called the basion. And that'll be important in some of the measurements we take. And the axis is the C2 vertebral body, and the axis is the C1 ring underneath the skull. Yeah? Sorry. So when we talk about craniocervical instability, most surgeons are thinking about acute instability following a motor vehicle collision or fall from a ladder. And they're looking at these findings. On the left, you see an opening between the base of the skull, the condyle, and the C1 lateral mass. In the middle, you might see lengthening between the skull and the odontoid, that red line. That's a prolonged basion dental interval. And in the upper right, increased space between the dens, the C2 vertebrae, and the anterior ring of C1. And when that reaches 7 millimeters, that's considered a critical level of instability. And below on the right, you might see the interruption of the tectorial membrane right there. And this is an unstable and stenotic craniocervical junction. So the interesting thing is, however, that acute post-traumatic craniocervical instability actually shares a lot in common with chronic instability of EDS. Namely, you need the clinical data to support the diagnosis. The CT findings are often not reliable. And in fact, the CT may be completely normal. And in fact, especially with EDS, a lot of the radiological findings are very subtle and would be deemed normal by most people. With craniocervical instability, atlantoaxial instability is very common. That's between the C1 and C2, because they share the same ligaments. So if you have instability between the cranium and the spine, you're likely to have instability in the upper two levels of the spine. And in many of these cases, there's an abnormal Bayesian axis interval, and I'll show you what that is in a minute. But if you look on the right there, these little red arrows, all of these patients had a prolonged Bayesian axis interval. So 12 years ago, the Chiari Syringomyelia Foundation, which is sponsoring tonight, brought together these 17 universities and established a consensus statement way back then that ventral brainstem compression or deformity or kinking of the brainstem was potentially injurious to the brainstem and upper spinal cord. Makes sense. And the deformation of the brainstem presents as a cervical medullary syndrome. So what is that? That's the presence of a headache and suboccipital or neck pain, and then bulbar symptoms. These are brainstem symptoms, including changes in vision, hearing, balance, vertigo, lower cranial nerves like dizziness, choking, dysphagia, difficulty swallowing, and dysautonomia, the abnormal functioning of the autonomic nervous system. And also symptoms of the upper spinal cord, so weakness, clumsiness, altered sensation, gait changes, and even things like urinary urgency and frequency. And third, the consensus agreement was that there were three metrics that would be useful in defining the population who might be appropriate for craniocervical fusion stabilization. Clival-axial angle, the Grabmap-Stokes measurement, and the Harris's measurement, and I'm going to discuss these now. And these three measurements have moreover been validated recently in the Journal of Neurosurgery by Marath and Failings. Failings used to be critical of the diagnosis of EDS, but now he's published a number of papers on the subject, so it's good that he's come around. In that manuscript, they note the importance of performing dynamic imaging in flexion and extension. Because if you have a ligamentous problem, lax ligaments, it stands to reason that that laxity will be most evident under the force of gravity in flexion and extension. So this is the clival-axial angle, and you see the picture of the brain here. And now we're looking just at this part here. Here's the clivus, and here's the axis C2, and that's a normal angle, but less than, somebody's not coming up here, but less than 135 is pathological, potentially. There may be people with 135 that have no symptoms at all, but when you get less than 135, you're getting into an abnormal level of kyphosis there. And we published an extensive review on the subject of clival-axial angle in 2018. Now, the Grab-Oaks measurement was actually described by a pediatric neurosurgeon in Alabama, and a line drawn from the Bayesian to the posterior inferior aspect of C2. From that line, a second line is drawn perpendicular from the dura to that line, and if that measures more than 8 millimeters, that's representing potentially compression against the front of the brainstem, and it's an indicator for possibly needing a fusion stabilization. So now the Harris measurement is the most important for craniocervical instability, and it's probably the measurement about which neurosurgeons have the least understanding. But back in the 90s, Harris looked at 400 normals, and he found that the distance between the Bayesian and the top of the spine was always less than 12 millimeters on X-ray. And the distance from the basion to the axial line, the BAI, was always less than 12 millimeters. So he said that if either of those measurements are 12 millimeters or more, then you have probably an unstable craniocervical junction. Now, those measurements on X-ray, 12 millimeters on X-ray is going to be like a little over 10 millimeters on a MRI or CT scan, because with X-rays there's a little magnification. Now, here's an MRI on the left, and you can see the basion axis interval there is more than 15 millimeters from here to there. And you can see that the brainstem is deformed and draped over the top of the odontoid. So that's clearly very abnormal. So that's one abnormal measurement, a long basion axis interval. But another way to look at this is dynamically in flexion and extension. And if you look on the upper right to the left, there's a flexion view, and we see a prolonged basion axis interval. And on extension, that interval decreases dramatically by about a centimeter in this case. And this is the patient down here. Now, normally the basion axis interval should not really change by more than a millimeter. More than 1 millimeter of translation is considered abnormal in the non-EDS population. In the EDS population, we allow 3 millimeters of movement, and I think more than 4 millimeters would be considered potentially pathological. And there's a fair amount of literature on that. Now, there's a famous neurosurgeon in India called Atul Goel, who's performed hundreds of atlantoaxial fusions, and who strongly believes that and it's true, that the C1, C2 segment is the most unstable in the body. There's up to 40 degrees of rotation to the left and 40 degrees to the right, and there's up and down motion as well. So that's C1-2 is the most unstable motion segment in the body. So he addresses all of his attention to that, and he says that the craniocervical junction, on the other hand, is a ball and socket joint like this, and it's one of the most stable in the body. So you may say, well, why are we talking about craniocervical instability if that's such a stable joint? And the answer is because that joint is not stable in the presence of many of these EDS and basilar invagination conditions. There's an excellent manuscript by Huang out of China of 80 controls, 63 patients with Chiari malformation and 42 with Chiari malformation and basilar invagination, these skull base abnormalities. And in the normal population, there is a very stable ball and socket joint, and there is no evidence of any instability. However, in the patients with Chiari and basilar invagination and these other issues we're talking about, there's flattening of this joint, which allows sliding or translation of the condyle of the skull on the top of C1. So that's how you get abnormal translation between the cranium and the spine. Now, moving down to C1-2, most patients, as I said, with craniocervical instability also have atlantoaxial instability. And this is mostly in the Ehlers-Danlos population of a rotatory form. And so if we look at if we cut the spine right here and look at it from the top, here's C1 and here's C2, and you can see that these bones have almost rotated off one another, and that's almost a dislocation there. So this is a rotatory subluxation That's what we most commonly see with EDS. And when it does that, it makes the spinal canal very small, obstructing spinal fluid flow and sometimes compressing the spinal cord. But if you look at this on an X-ray from the side, it may look quite normal. So it's a little confusing to people who are not familiar with rotatory subluxation. And this is due to abnormality of the alar ligament. And Chris Centeno in Colorado and his group are famous for trying to improve the strength of that ligament with stem cells and so on. So that's the alar, and here it is on a coronal front view in black, and here's a alar ligament that's broken right there. And so we can diagnose rotatory instability with a rotational CT scan, where the patient lies on their back supine and a CT with the head rolled to the right in this case. And we see the C1 ring is rotated in the middle view 85 degrees, and the C2 vertebra is rotated 40 degrees. So the difference is 45 degrees, and that angular displacement is 45 degrees, with 41 degrees being the threshold. So when the angle between C1 and C2 exceeds 41 degrees, then you're in the realm of potential rotatory subluxation. And we can do a 3D CT, and you might notice this area here, that's the superior facet of C2, and it's almost uncovered by the facet of C1, so that's almost dislocated. And so when you lose that coverage, when the facet sublux that much, my threshold is 90%. When there's loss of 90% of coverage, then you have instability. Another way of looking at instability at C1-2 is with a DMX, the digital dynamic fluoroscopy. And looking at an open mouth view, you can see the C1 ring here sliding sideways off C2, and you might see a gap there of about 6 millimeters right here. No, the normal person slides no more than 1.6 millimeters, so our threshold is twice that, 3 millimeters. If there's more than 3 millimeters lateral translation, then they might have atlantoaxial instability. So I'm going to give you the results of craniocervical fusion stabilization in 53 patients with Ehlers-Danlos syndrome. And so our indications are the presence of a severe headache, more than 7/10, the presence of the cervical medullary syndrome, which we discussed, the brainstem and spinal cord symptoms and findings, the neurologic deficits, which include the lower cranial nerves and vision and vertigo and weakness, sensory loss, hyperreflexia at the knees, the pathological reflexes, and then the radiological findings. And in this study, there were 50 women, 3 men. Men being the stronger of the species don't have this as much. I don't mean that in a... No, I do, but anyway, sometimes we get CT angiograms, and not infrequently we see that the vertebral artery, which is right here, ending in the posterior inferior cerebellar artery, and it doesn't go up to join the basilar. So this artery relies on the integrity of the opposite one to backfill. And if this one gets compressed, the left one, then you can get ischemia, intermittent ischemia in the brainstem and transient neurologic deficits. And in this case, on the picture on the right, with bending of the neck, there's obstruction of the vertebral artery. And in this case, the vertebral artery entered one level lower. So if you weren't aware of this, you could cause a arterial injury putting in the screw. In these EDS patients also with Down syndrome, the vertebral artery can have a very abnormal position on the C1 level. And in addition, the pedicle, the anatomy through which we place the screw, can be extremely small, so that it can be very difficult to place these screws. And the best of times, the screws come within 1 or 2 millimeters of the vertebral artery. So the most dangerous part of the surgery is correctly placing the screws to avoid any arterial injury. And the same at C1 as C2, the blood vessels are very close to where the screws are. Now the occipital nerve, the dorsal root of the C2 spinal nerve, exits between the ring of C1 and the lamina of C2, and is particularly vulnerable to any kind of chafing on with movement. It's one of the causes of severe headache, jostling about in a car on a bumpy road. It's the C2 nerve root being compressed by the bones. So when we perform this surgery, when we see the nerve, we take it, and now we're actually looking for it under the microscope. We dissect it out and take the dorsal root to avoid occipital neuralgia either after surgery or a year or two later. We don't want patients having to come back for surgery down the road. So that's the occipital nerve. Now in the surgery we perform traction reduction to get the best alignment. And so here's the skull, and that's the clival-axial angle. We extend the head to get the optimal clival-axial angle. And we also want the mandible axial interval, the distance between the mandible and the spine, to be somewhere, but as seen on an X-ray, to be between 1 centimeter and 24 millimeters. If it's less or more, it can cause difficulty swallowing. And then we also want the optimal gaze angle, which is the angle at which people hold their head. We don't want them stargazing, and we don't want them looking at the ground. So we try to get the what we call the orbital axial angle, approximately 100 degrees. Now in this series, we're able to correct the kyphotic clival-axial angle to eliminate the ventral brainstem compression in every case. And out of 53, I think we had 1 fusion failure. This is a midline picture showing the bone growth between C2, C1, the skull base. We use this system that we actually developed and patented, but belongs to the company now. But this uniquely actually holds the bone graft in place, so it makes for a very solid construct. And it's low profile, smooth, so it doesn't cause pain on the back of the head. That's a 3D reconstruction there. That's what it looks like in surgery. So this is a little bit confusing, but we saw good pain scores on almost post-operatively in almost every patient. And at 1 year, the pain level, and these are patients we did about 6 years ago now, but pain levels came down from about 8.5 average to about 6. But now, for some reason, the patients seem to be getting quicker pain relief, and many of them are leaving the hospital in 1 or 2 days, which is surprising. Looking at all these patients, we saw a statistically significant improvement in phonophobia, sensitivity to noise, vertigo, dizziness, the headache and neck pain, syncope, that's fainting, pre-syncope, poor concentration, poor memory, double vision, photosensitivity, facial numbness, leg weakness, arm weakness, nausea, vomiting, incoordination, speech difficulty, and fatigue. So we saw significant improvements in all those, and on the right side, there's symptoms associated with a poorly functioning autonomic nervous system, dysautonomia, and we saw improvement in all those symptoms as well. Orthostatic grading scale, there's improvement in the orthostatic symptoms. Now, these symptoms weren't gone by 1 year, but they were substantially better. And with good physiotherapy and cardiovascular exercise, these symptoms tend to keep getting better. Many of these patients need midodrine as well. But we saw significant improvement in orthostatic symptoms, and on the right, the memory issues, thoughts, poor concentration, difficulty making decisions, slow thinking, foggy head, all of these symptoms improved significantly. This Konofsky score on the left, blue is before surgery, and with an average around 50, these patients were very disabled. And after surgery, the Konofsky score improved to around 70. So the majority of patients returning to university had many get their PhDs, and many go back to being taking care of their family or going back to school or work. Looking at whether patients would repeat the surgery, 96% said they would repeat the surgery. 3 said they would not repeat the surgery. But many patients, even after the surgery, had many issues with their comorbid conditions. And the average patient had 6 comorbid conditions, and some patients had over 20 comorbid conditions. And that's the full list of comorbidities that we saw. And so one of the reasons I like to see people at 3 months and even later is to help deal with all of these other comorbid conditions. And my interest is not fusing the craniocervical junction, but getting people back to a real meaningful life. And that means dealing with all of these other issues. So there's no difference between those patients with low-lying cerebellar tonsils and CSF flow obstruction, for whom we performed a decompression, and the patients who didn't have those problems. They all did about the same. So the Chiari did not affect the outcomes. We had no intraoperative complications. We had 4 of the 53 patients who had a wound dehiscence, usually about a month after surgery, that had to get repaired, and 1 who may have had an infection, although the culture was negative. But we've made some changes now, and we've not had any wound dehiscences in the last 18 months. So that's right. What about loss of range of motion? And I've heard many surgeons express real dissatisfaction with the idea of fusing the skull to the spine because of loss of range of motion. But especially in the EDS population, range of motion is not an issue. This is a woman who's 1 month after her craniocervical surgery, and she wanted to make the point that she drove 100 miles in to see me at the 1 month appointment, and she said range of motion is not an issue. But I have to say that after this surgery, I'm telling patients to try to keep their head straight, turn with their body more, and not wear out the rest of the spine by turning their neck too much. And by observing that simple rule of maintaining good posture and avoiding excessive movement of the neck, I think we've cut down the number of lower cervical surgeries by about 2/3. So we're talking then about adjacent segment degeneration, which is a big concern of people, that if you fuse the top, that you're more likely to wear out lower down. But I will say that right below the fusion at C2-3, it's exceptional. It's very rare that we ever see instability at that level. And if they follow that rule of posture, avoidance of unnecessary neck movement, avoiding looking at the cell phone, then the risk of needing more neck surgery is about 30% if they follow those rules. Thanks. Let's see. Okay, so what is causing all of these problems? And so here's a brainstem, upper spinal cord in the neutral position, and with neck rotation, there's a great deal of torsion on the brainstem. So it should be, I think, intuitively obvious to you that if you twist the brainstem, you're going to cause problems. And we actually patented a mathematical predictive analysis of brainstem torsion and stretch, and correlated it very well with clinical findings. This was work 15, 20 years ago. And we proved to ourselves that mechanical deformity and stretch does correlate very well with neurological symptoms and outcomes. When we corrected the stretch, the pain and the deficits went away. And this has more recently been validated by other researchers. Well, when you twist and deform the brainstem, you also twist and deform these sympathetic fibers here, and that, I think, contributes significantly to the overall dysautonomia. And I will mention that the autonomic nerve fibers speak to the mast cells throughout the body. And so when we when we improve the autonomic nervous function, a lot of the mast cell activity improves, but not always, but most of the time. It's also been shown if you stretch a nerve, you cause the myelin to disassociate, and you get clumping of the inner parts of the nerves and formation of these axon bulbs. And more illustratively, if you look at this rat optic nerve stretching 20% of its length, in 3 days it develops these axon retraction bulbs. So the same thing we see with diffuse axonal injury in the brain following trauma. And if you stretch nerves, it can also allow this calcium influx into the cell, which can be deleterious. And stretching the nerves finally can trigger apoptosis, which is programmed cell death. Finally, the most obvious cause of many of these deficits is the decreased blood flow through the vertebral arteries. When you attenuate the artery from rotation, you can cause ischemia. And this is particularly evident when there's one artery much bigger than the other, or there's some anomaly of the circulation there. So in conclusion, the severe headache and neck pain, symptoms of the cervical medullary syndrome, especially the weakness, lower cranial nerve dysfunction, and long tract findings, which are hyperreflexia and Hoffman other pathological reflexes. These things should prompt the consideration of craniocervical instability. And this diagnosis is facilitated by dynamic upright flexion extension imaging of the cervical spine. If necessary, you could get a CT scan lying down, but that's not nearly as accurate. You're not dealing with gravity. It's not a physiological position to be lying down flexion extension. And normally, if you have horrible instability in your neck and you're simply lying flat on a table, that spine can appear completely normal because you're not stressing the ligaments. You have to stress them to show the instability. The horizontal Harris measurement is very useful to assess potential instability at the craniocervical junction. And if the appropriate reduction, meaning alignment and fusion stabilization, occiput to C2, is associated with significant improvement of those neurological symptoms. And we still have some work in terms of refining the diagnosis of the population to operate upon, and learning about the pathophysiology of what's happening, but especially the epidemiology, the natural history of what's happening to these patients who get surgery and who don't over the long term. So this is a boab tree. My brothers and I, in the Northern Territory of Australia, where we used to have a cattle station, don't anymore. And that is a tree I'm standing in front of. All right, thank you for your attention.